Hello, everyone, and I hope everyone is having a nice, relaxing evening and you have a drink in hand because we're going to be talking about addressing the gap and improving lymphedema patient experience in today's healthcare system. I'm Tony Gasparis. I'm the moderator for tonight's event, which is put together by Tactile Medicare and Medicine. And with us today, we're going to try to address this gap through the lens of three different specialties and from a wide range of practice, from private practice to academia. And we're going to kick off with Dr. Stan Rockson, who is a professor of cardiovascular medicine from Stanford. And he's going to present to us his recent paper publication on the perspective of lymphedema from the patient perspective. As always, please submit your questions through the Q&A box at the bottom there. And for those who can't make it today, or if you want to listen to this later on, you'll have access to it as this is being recorded for a future playback, which will be hosted on the Tactile Education website. So we'll proceed now with Dr. Rockson and Stan to kick it off.
Thank you, Tony. It's really a pleasure to be here this evening, and welcome to everybody who's giving us a bit of your time to discuss what we all think is a very important topic. I will be talking about the patient experience within the healthcare system. I will be talking about lymphedema in specific, and more specifically, zeroing in on the problem as it relates to non-cancer provoked lymphedema. So next slide, please. This is by way of introduction to the problem of the patient experience. This is a direct quote from one of the participants in the study that I'm about to talk about. My GP told me there was no such thing as lymphedema. It was all in my head. And while she was berating me about it, I got up and left. This is unfortunately an all too common experience, or ones like it, that very much color the patient experience, and that's what we'll be talking about this evening. Next slide, please. So I'm going to be highlighting material that we published last year in scientific reports in a peer-reviewed publication about the patient experience. This publication was an outgrowth of a competitive grant that I received from the Centers of Disease Control, the CDC, to look at the problem of lymphedema as a chronic disease. And specifically, I was charged with creating what's called a national indicator report to try to make a snapshot of current medical care surrounding lymphedema in the United States. And as a subtext for that particular experience, we conducted this prospective investigation. Next slide, please. Our objectives were to address the problem that there is minimal epidemiologic documentation on how widespread the impact of lymphedema can be. And so we attempted to more or less take the temperature of the problem, to summarize the clinical characteristics and interactions of lymphedema patients within the medical system, to try to more formally investigate what many of us as clinicians already experience subjectively from our individual patients, which is a report that they are underserved by the system, and to identify potential opportunities. Next slide, please. So the tools that we utilized were two. The primary tool was on the right-hand portion of the slide, the patient interaction cohort, which was a 23-item online questionnaire that we created to interrogate the lymphedema community as identified within social networks. And with this methodology, we were able to engage over the period of observation with slightly over 2,300 patients with self-documented lymphedema. In order to validate the contents of this anonymous questionnaire, we also had access to a global registry for which I serve as the principal investigator, using a much more extensive online questionnaire. And here we had a sampling size of slightly over 500 as a validating cohort. Next slide, please. So this is just, again, a schematic representation of the interaction between the two interrogations. Next slide, please. So this is a detail about our statistical approach, which I think is probably of less granular interest this evening, but just by purpose of validation of the fact that we approach this in a statistically rigorous manner. Next slide, please. So overall, we had 2,548 participants, of which 539 were in the registry cohort and 2,319 in the health interactions cohort. As you can see, not every patient completed the entire questionnaire, and accordingly, we limited ourselves to just those sub-cohorts that actually completed all questions. This was a very representative population, middle-aged, about 55 years of age, and as we always see in lymphedema cohorts, very predominantly female. There is a great deal more detail on the slide here that we don't really have time to go into. Suffice to say that this was really a very representative slice of the American lymphedema population. Next slide, please. So, as I mentioned, we had both cancer and non-cancer related lymphedema, but I'm going to zero in on the non-cancer related lymphedema for the simple reason that among the more enlightened clinicians that actually deal with lymphedema or acknowledge lymphedema, there is a growing recognition of the relationship of many of these patients to prior cancer therapeutics. Where we're going to see there is a much bigger problem that remains is in the so-called non-cancer related lymphedema, which in many individuals' experiences is the fastest growing subset of lymphedema, representing both the impact of obesity and venous hypertension as big growing segments of the total lymphedema population. Next slide, please.
And do you think that growth in secondary lymphedema from either venous, I mean, obesity, I understand with the increased incidence of obesity in the US, but do you think it's because of the increase in venous disease or just recognizing that contribution of venous disease to lymphedema?
My opinion would be predominantly the latter, but because the obesity epidemic is actually ongoing and increasing, I think there are spillover effects in terms of sheer incidence and prevalence as well. So I think it's a combination of both, but thankfully recognition is growing, which is an important part of this. Here on this slide, you will see both good news and bad news, and we're going to focus a little more on the bad news today. If you look at the organ pipes that represent cancer in white and non-cancer related lymphedema in gray, you'll see that thankfully, by today's standards, at least half of the cancer-related patients are able to receive a diagnosis consulting with a single physician. Contrast that with what happens in non-cancer related lymphedema, where at least 30% of the population have to see 5 or more doctors before there is an ascertainment of the diagnosis. So here you see quite a disparity with the organ pipes for cancer-related lymphedema oriented toward the left of this slide and the non-cancer very much oriented to the right. Next slide, please. Similar problem with regard to symptom onset to diagnosis. Over 60% of the non-cancer related cases have to wait more than 12 months after the onset of symptoms before they receive a diagnosis. In cancer, 30% get a diagnosis within the first month, and a similar proportion in aggregate, 60%, will have a diagnosis within 3 months of onset, as contrasted with greater than a year before a diagnosis is assigned. Next slide, please. Lymphedema referral patterns reflect a similar disparity. So you'll see that among the cohort in general, there were 3 broad categories: those that were self-referred to a lymphedema therapist, those who received a referral to a therapist, presumably from a healthcare provider, and those who were never referred to a therapist. So you can see equivalent percentages, more or less, are either self-referred or referred to a therapist, both in cancer-related and non-cancer-related cohorts. But disappointingly, 3 times as many patients with non-cancer lymphedema as to the cancer-related group are never referred to a therapist. So this is a problem that we need to solve, and it keeps company with the data that I showed you on the prior slides. Next slide, please. So time from symptom onset to lymphedema treatment. Again, bad news for the non-cancer related group, in which we see a delay of greater than 1 year for onset of treatment in over 60% of these patients. And you can see that the differences among cancer and non-cancer cohorts are highly significantly different, especially this late cohort where only 20% of the cancer-related patients have this delay of 1 year and 65% experience the delay if they're in the non-cancer group. Next slide, please. So this is a kind of summary slide in which we asked the patients using a kind of visual analog scale to grade the impact of lymphedema on various aspects of their life and various aspects of their entrainment within the healthcare system. Not surprisingly, both cohorts of patients report an overall negative impact on quality of life and functional well-being, but that impact is slightly more devastating in the non-cancer related group than the cancer related group, which is surprising in its way, insofar as the cancer group is already dealing with the negative impact of the morbidity of the cancer and many other aspects of cancer-related therapeutics. Not surprisingly, also based on the data we've just seen, both cohorts feel relatively equivalently that healthcare providers are basically uninterested in the problem of lymphedema. So they don't feel that they are received by the healthcare environment with a level of interaction and engagement that makes it seem as if the problem is important to the healthcare provider. Consequently, their satisfaction with lymphedema treatment and diagnosis is also significantly negative, and again, more so for the non-cancer related group than the cancer related group. So the impact of this particular manuscript and the data that it describes is that we have a lot of work to do to make our healthcare environment welcoming and rewarding to the lymphedema patient, especially if the problem is outside of the cancer-related realm. So my final slide will follow. Sorry, next to final slide is a simply, all right. Just to summarize that this was the first formal quantification of the burden of relative disease neglect that is faced by lymphedema patients. Again, there is a myth that has surrounded lymphedema among practitioners over decades that this is in fact what is going on. But as to my knowledge, this is the first formal documentation of the extent and severity of this negative healthcare interaction. And we were able to demonstrate alignment with our anonymous cohort and a smaller cohort in a registry that is more definitively identified through a more extensive intake of information. And the final slide is to demonstrate the points of interaction at which we, as healthcare providers and as a healthcare environment, can improve our response to these patients. So every asterisk that you see on this schematic represents a place in which there is an interaction or potential interaction with the healthcare providers that can provide an acceleration of diagnosis and therapeutics. And you see illustrated with the schematic clocks those places where there is a significant delay and where we can certainly interrogate our interactions with these patients to determine that we can provide better care. So with that, I will conclude my comments and turn it back over to Dr. Gasparis. I just want to acknowledge the funding from the CDC. My main collaborator was an MD PhD student at Stanford who's earning her PhD in epidemiology and helped me greatly with the statistical analysis of the data. I'm very grateful to the participants who gave us their time and also to the Lymphatic Education and Research Network, who was a willing partner in this work. So thanks very much for your attention.
Thank you, Stan. A couple of things, that I took away from this, obviously, like you said, cancer-related lymphedema did better than the non-cancer group. But you know, that doesn't mean it was great either. Because,
Right.
you have a group of patients that you expect to have, a risk of developing lymphedema, yet even though, the flag is up and showing you the road there, you still, a good chunk of patients took a while before they were diagnosed. And maybe that's why
Absolutely.
their
Absolutely.
their 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 scores were just as bad as the non-cancer related lymphedema. Um, and actually, one of your summary slides are kind of, and we all kind of knew this. I think everybody knows. And actually, one of the comments of one of the attendees says that, there's lack of trained MD to recognize physicians to recognize and provide treatment. Um, and I know you had that little flow chart. What would you say if you had, and this is one of the questions, recommendations as far as how we can address this issue? Let's say top three things that you would think would help uh, increase.
Well, actually, I have some semi-formal answers to that. Some on the call may know that I'm currently chairing the National Commission for Lymphatic Diseases that was commissioned by Congress through the NIH. We're just in the process of delivering our final report. And what we've concluded, among many conclusions, is that the problem in formal medical education right now is that few, if any, certifying examinations actually interrogate knowledge related to the lymphatic system. So at a fundamental level, we need to engage with all of the societies and organizations that are responsible for certification to be certain that at a more general level, this material is interrogated because that indeed drives medical education curricula and medical reform. I think we also need to acknowledge that even if we solved every problem in the medical schools that exist today, we have a cadre of practicing physicians who are going to be out in the field for the next 20 years based on the education that they've already received, that are not going to be impacted necessarily by this reform. So there is a crying need for continuing medical education. We certainly need tools that are readily available to the practicing community in order to refurbish their lacking education in many cases and provide the information that they require, and making those resources available in a manner that's most efficient, and also allowing the patient community themselves, who I think can be a voice in this dialogue, to motivate their clinicians to become aware of the imperatives that exist because of their diagnoses, and train them into the post graduate educational process in order to make sure that they receive the care that they require.
Now, the other limiting step, though, and again, let's assume we're successful in educating all these physicians out there. So
Hmm.
there are enough therapists
Correct.
to even offer therapy to these patients out there.
Absolutely.
So I think there's a lot of gap, that
Yes.
can be
And
addressed.
there are health economic barriers as well, as we know. Sometimes it's not even when the path forward is indicated for the patient, the reimbursement mechanism may create barriers that don't allow the patient to follow that path. And so we need some reform in that direction as well.
Tony, want to add one thing. I agree that there's a lack of physicians that are trained or willing to treat these patients, but these patients cross paths with multiple other healthcare providers, physical therapists, although they may not be lymphedema specialists, wound care nurses, and the like. And any of those providers can initiate or advocate for the patient to get the care that they need. So, yes, education of physicians is important, but you know, everyone should feel like they could advocate for these patients and initiate proper therapy.
No, absolutely. All right, Chris, I think Dr. Compton is going to take over now. And Dr. Compton is a private practice vascular surgeon out of Tucson, Arizona, right, Chris?
Yep.
And he's going to take over.
Thank you. Dr. Rockson, thanks for the information. It's very eye-opening to see those numbers. And I do see that in my clinical practice, the delays in referrals. I just saw a patient yesterday who's had venous stasis ulcers for 2 years that she's been trying to manage herself at home, and it took 2 years for her to get the referral. So it does happen on a daily basis. I wanted to talk a little bit about what lymphedema is and what causes it, and maybe dispel some myths about it. So lymphedema occurs when the lymphatic system can't keep up with its job of returning interstitial fluid to the vascular system. 20 years ago, we were taught that it was mainly the venous system that was primarily responsible for emptying the leg, but it turns out that's not the case. It's actually the lymphatic system. And when I initially started treating these patients, I tried to be very academic about it and try to really get down to what is the one source of their edema. Is it congestive heart failure? Is it chronic venous insufficiency? Is it primary lymphedema, secondary lymphedema? And the bottom line is it's kind of unnecessary because anything that causes edema that persists eventually results in lymphedema. So, in medical school, we were taught that congestive heart failure is a completely separate process. Congestive heart failure has pitting edema, whereas lymphedema is non-pitting edema. But basically, edema starts out as non-pitting, and as the lymphatic system gets damaged from the protein-rich fluid, it it advances and eventually becomes inflammatory and becomes permanent. So these aren't distinct processes. They're intertwined, and very rarely does a patient have one distinct cause of their edema. It's usually multifactorial. It could be a little component of congestive heart failure. It could be a component of lack of calf muscle pump function. But the bottom line is all of them together eventually result in lymphedema. So initially, I wasn't doing my best for these patients, although I was trying to, because I think I was too selective at making that lymphedema diagnosis and not getting them the treatment that they needed. But the bottom line is, if somebody comes to your office and they've had edema for 6 months, a year, especially if they have skin changes, by definition, they have lymphedema. And I don't necessarily need a study to tell me that. Next slide, please. So historically, many of us have associated lymphedema in the United States with a cancer diagnosis. And it's true that at one point, cancer was the leading cause of lymphedema in the United States. Worldwide, it's always been parasitic infection. But more and more, we realize that chronic venous insufficiency is actually the number one cause of lymphedema. And this is from a study from physical therapy practice associated with the cancer center, so skewed a little more towards the cancer population. But even that population, when they investigated the source of the patient's lymphedema, by far number one was chronic venous insufficiency. And Tony, you brought up the point earlier. What's going on? Why are we seeing more of this? And absolutely, I think obesity plays a big role. I mean, the incidence of obesity is increasing, certainly, and that increases the pressure on the lymphatic and venous system. But also, we have seen a significant increase in venous thromboembolism in the United States. Obviously, there was the massive increase with COVID, but even prior to COVID, the incidence of venous thromboembolism was increasing pretty steadily in America. And I think that, along with obesity, is contributing significantly. Next slide, please. So this is the SEEP classification, the clinical scaling of venous insufficiency, and it ranges from asymptomatic venous reflux that we'd only see on ultrasound, all the way to active ulceration on the far right with C6 stage. And what we've learned from a clinical and also basic science standpoint is that as you progress along the severity of venous insufficiency, you very closely parallel that with degree of lymphatic insufficiency as well. So as you're looking at this scale, you're going to see on the left just some varicose veins, moving to the right, edema, and then from C4 up, you start to see skin changes. And it's important to document those skin changes because not only do we want to monitor the patient's progress, but it also is very helpful in getting the patient's treatment approved if you document the skin changes such as hyperkeratosis or ulcerations. Next slide, please. This is from a study in the Journal of Vascular Surgery. And what they did was they took 12 patients with venous stasis ulcerations, most of them unilateral, and they did a fluorescence lymphography study on them. So they did it bilaterally, so they're able to look at the ulcerated leg, but also the non-ulcerated leg, which very likely had a different degree of venous insufficiency. And if you look at the far left, you'll see what healthy lymphatic flow looks like. It's very linear, organized, not much pooling. If you look at C0, which is a degree of venous insufficiency that has no outward manifestation, just something that we pick up on ultrasound, already you're seeing on lymphography that there's lymphedema, pooling of the lymphatic flow. And as you go all the way up to C6, active venous stasis ulceration, there's very disorganized lymphatic flow. So lymphedema and chronic venous insufficiency are completely intertwined. You can't really have one without the other. As I mentioned early on in my treatment of these patients, I was thinking that chronic venous insufficiency was a separate process from lymphedema. But the bottom line is, if you have significant chronic venous insufficiency, by definition, you're going to have lymphedema as well. Next slide. So how do I evaluate these patients? Of course, history and physical is very important, probably the most important. I want to document a pulse exam if I can. It can be very difficult to feel the pulses in these patients with their, edema and, potentially thickened skin, but history and physical is very important. As I mentioned, I'm going to document those skin changes. I want to document risk factors because these are modifiable quite commonly. As we mentioned, obesity is contributing significantly these days to lymphedema, and so that is a modifiable risk factor. Also, exercise can be important. So if somebody's very sedentary, they're losing that calf muscle pump function. So that's something we can counsel the patient on. Now, initially, when I started treating these patients, I would always immediately get a venous reflux study and an arterial Doppler study. And I wanted to be thorough, and I thought that, kind of differentiating anatomically and physiologically what was the source of their edema was important for their treatment. As I mentioned, I think I was doing a disservice to them because if somebody comes in to my office with a swollen leg, especially with skin changes, I need to initiate treatment. I'm not going to wait for a venous reflux study. It doesn't truly matter what it shows. I mean, whether the patient has venous reflux or not is not going to change what I initially try to treat the patient with. So I don't want to delay getting them the treatment they need. So even before getting a venous reflux study or even an arterial Doppler study, I likely would initiate compression pumps. An arterial Doppler study is very important before you put an Uniboot on somebody. If you can't feel a pulse in someone's foot and you put a compressive bandage on, that can actually cause real harm. But the nice thing about the pneumatic compression devices is that the compression is intermittent. It only lasts for a second or so. It's only 60 millimeters of mercury. So even if the patient had arterial insufficiency, it's very unlikely that with a lymphatic pump that they would have any real harm if they used it. Now, sometimes if they have severe arterial insufficiency, it might be too uncomfortable for the patient to use the pump, and that's something to keep in mind. But I'm not going to necessarily get an arterial Doppler study before I initiate a pneumatic compression device. And I don't, I know not all vascular surgeons feel that way, but that's how I approach it. Lymphoscintigraphy, fluorescence microlymphography. It's really nice to have that information on a basic science level so we can understand what's going on. But I never order these studies because, again, it's not going to change how I treat the patient. Next slide, please. So this is the staging of lymphedema ranging from 0 to 3. So 0 is basically no real outward manifestations, minimal edema, no skin changes. Stage 1 is completely reversible. So these patients will have edema, but they haven't progressed to that inflammatory or scarred phase yet. So typically they will report that by the end of the day, their extremity is quite swollen, but after they go to bed and they're sleeping and they wake up in the morning, their leg appears very normal. So at this stage, it's completely reversible. Stage two is when they no longer have pitting edema, it becomes non-pitting. And that's because the inflammatory changes that happen at the lymphatic and subcutaneous level, you have some scarring there. And it's fairly easy to get patients approved for a lymphatic pump at stage two if you document the skin changes. But if we let the patients get to that level, we're really doing them a disservice because although we can help them and we can reverse a lot of their changes, if we let them get to lymphedema stage two, they'll never be quite normal again. So in reality, if we're going to do the best for the patients, we really should be referring them for treatment at stage one. When it's pitting edema, it's reversible because we can reverse so many of these changes that they can probably be normal again. And it's sad that in the United States we still see elephantiasis stage three, but as Dr. Rockson pointed out, it's because the patients aren't referred for proper treatment in a timely fashion. Next slide, please. So treatment. Obviously, education is important so the patient can understand what they can do to improve this condition. The basics involve elevation, exercise if the patient can, take advantage of that calf muscle pump function. Manual lymphatic decongestion can be very helpful. Over 50% of patients are going to see improvement. In my practice, unfortunately, it's hard for me to use that because we only have one lymphedema therapist in Tucson, and they no longer take insurance. So it can be difficult to get patients in to see them. And also, even for those that do take insurance, quite commonly, insurance will only cover it for 6 weeks or so. So it's nice if you can get your patients into the lymphedema massage therapist. They can really do some good, but it can be challenging to maintain that or even get it approved through insurance. And of course, pneumatic compression is kind of, in my opinion, the ultimate and the best treatment for these patients. There's some adjunctive things, of course, weight loss can be a benefit. If somebody does have significant venous reflux, it's not going to be my, go-to first line therapy. I'm going to do static compression. I'm going to do a lymphatic pump before I recommend that, but it can be helpful in certain cases. Next slide, please. This is from a study that Dr. Rockson was involved in, and it looked at patients who had the diagnosis of phlebolymphedema, so venous insufficiency related lymphedema, and it followed them over a course or looked at them, their insurance claims over a course of over 18 months. And it compared conservative therapy with the elevation, lymphatic massage, compression, etc., versus a tactile flexi-touch advanced lymphatic pump, and also basic pneumatic compression as well. And what you see here is there's a dramatic reduction in healthcare dollars for these phlebolymphedema patients when you prescribe the proper therapy. So if you look at conservative therapy versus conservative therapy with the addition of a flexi-touch advanced pump, there's a 69% reduction in healthcare costs for the patient. And if you look at simple pumps versus a flexi-touch, again, fairly dramatic reduction in healthcare costs. And on the far right, we see conservative therapy with other brands of advanced pneumatic compression versus conservative therapy and a tactile flexi-touch. Again, significant reduction in healthcare expenditures for these patients. And the reason is that we're keeping them out of the hospital. They're not getting recurrent cellulitis episodes. They're not getting recurrent ulcers. These ulcers can take a long time to heal. It involves, many physician visits, dressing changes, antibiotics, hospital admissions. And so, I like to be a good steward of our healthcare dollars. I want to make sure that what I'm recommending, if there's a cost to it, that it's likely to save the healthcare system money. And I think very, very confidently I can say that when I prescribe a FlexiTouch pump, I know that in the long run, it's going to save the patient and the healthcare system money. Next slide, please. So this is really nice. Tactile keeps this data for our practices. It's the medallia results. And this is compiled from, interviewing patients. And you can see there on the top, the overwhelming majority, over 80% of patients report significant improvement in their edema and their symptoms. And their overall satisfaction is quite good. I mean, we've got room for improvement, certainly, but 4.2 stars in a patient population that generally is dissatisfied, I think is quite encouraging. And I've been working with Tactile for about 5 years. I made a conscious decision about 10 or 15 years ago that I was willing to treat these patients. And I'll have to say that prior to working with Tactile, it wasn't the most rewarding experience for me. I mean, yes, I could get the patient through whatever acute episode they were in. If they had cellulitis or an ulcer, I could get it healed. If they needed an ablation, I could do that. But when they were healed and I was kind of releasing them back into the wild, I knew that if the only thing that I could offer is compression socks or static compression, the patients would just be in this never-ending cycle of healed and then months later breaking down, infections, ulcers, and whatnot. And so it's kind of a frustrating patient population to deal with. But since working with Tactile, I really have the confidence to tell people that we can prevent these problems, you know. If you're dedicated to using your pump, after I get you healed, you can put yourself in a situation where you will never have another ulcer again. And so it's been very rewarding for me. Next slide. That's all I have.
Thanks, Chris. Definitely agree. These patients can be challenging, and that's why I asked Dr. Rockson earlier about how to, uh, even if we educate all the physicians and we identify all these patients, just like we're seeing more lymphedema to the venous disease because of awareness, if every primary care out there and other specialty recognizes this, then the system is going to get overwhelmed with an influx of patients that can't really be supported with you know, physical therapy. So definitely having all these adjunctive tools does help getting these patients care early on. Because even I'm in Long Island. I mean, you would think in New York there's no problem getting physical therapy for lymphedema, but it's 8 months waiting period. And we have at least a half a dozen centers in our area, so it is a challenge.
Definitely.
Any other comments from the other speakers? What are the audience? How do you get a pump approved before they are in any compression first? Are they more likely to be compliant with a pneumatic pump or running compression wraps first to start with? I think for the most part, personally, they all get into compression as a first-line therapy. Um, and obviously then get them into a pump if they fail. Um, how about you guys?
Yeah, I mean, most insurances do want to see at least a month of static compression. But from what I understand, and maybe somebody from Tactile can chime in, with the Lymphedema Act, if you evaluate the patient a month apart and get two measurements, even if they haven't done static compression, they can qualify for a pump. And a lot of these patients have difficulty even getting compression socks on, and uh, a lymphatic pump is actually easier for them to get on because they can leave the foot straps kind of already deployed and just slip their foot in like a slipper and then zipper, fasten themselves up the rest of the way and hit a button. It's actually a lot easier for them than compression socks.
Stan, can I ask you a question?
Yes. Yes.
So one of the questions in the audience is, how do you respond to healthcare professionals that claim that pneumatic pumps make the clients more dependent on these devices, and because of that, they don't recommend?
Gosh, I can literally say, seeing 1,000 new patients a year, I have never heard that before. But I think the answer would be analogous to, I'm not going to give Lasix to my heart failure patient because they're going to be dependent on the drug. If somebody has an absence of health and there is an intervention, whether it's a drug or a device that reduces symptomatology and improves function, we want that kind of dependency. So I think it's to me, it's a very specious concern. We as physicians provide resources to patients to reduce their symptomatology, and they then will depend on those resources to keep the symptoms from recurring.
Thanks. I agree. I mean, I have never heard that either, of somebody being dependent on their pump.
Right.
If obviously the bigger problem typically is, compliance rather than
Exactly.
so we'll move on with Dr. Foghi to wrap up tonight's event. And Dr. Foghi is an interventional cardiologist from La Jolla Vein in California, and he's going to talk to us a little bit on his experience.
Thank you, Dr. Gasparis. Thank you, Dr. Rockson, for amazing presentation, eye-opening, and I really hope that this kind of a work was done when I finished medical school, so we wouldn't be in this situation we are right now. So amazing. And Dr. Compton, amazing talk for setting up the stage for what I'm about to talk. I'm going to try to somehow bring everything together right now, and I'm going to refer back to what Dr. Rockson and Dr. Gasparis kind of touch up upon the lack of familiarity with our medical society and medical education with lymphatic disease and system. So next slide, please. So the best way to bring this up, I thought maybe I use this analogy. Everybody on the right side probably familiar with the three tenors, and we all know who they are: Placido Domingo, Luciano Pavarotti, and yes, nobody knows the third guy. Everybody, I haven't seen anybody just raise their hand and yell the name. Same thing, same analogy works in regard to our vasculature and vascular system in the body. You ask anybody, artery, vein, and who's the third guy, you don't know. So Mr. Carreras on a third tenor is equivalent to our lymphatic vessels and lymphatic system in our medical schools that we do not study it. We don't even know what it is. I think the last time I did a study lymphatic was the night before my exam, and that was it. So I think the initial part of this program to be changed is not putting education or continuing education. It's maybe coming up with a specialty program for lymphatic vessel and venous disease, because it's becoming extremely prevalent now. And every study that has been done, either in this country or outside, is pointing towards that. It's a time for people involved with academia to think about this truly, to make it its own kind of a professional kind of a program to be able to educate our future doctors or physicians. Next slide, please. So the whole concept of, I'm going to take you to a journey of clinician. I work in academia, I run the hospitals, I've done cardiology, but about a decade and a half, I made a conscious decision that there is much more needed of us to contribute our life and education and skills to venous disease and lymphedema. So made the decision to switch sides and become very involved with the venous disease and treatment. And ever since I work in clinical setting, one of the first things that gave me the idea is a diagram on the right side. This is a capillary bed. And in medical school, for some reason, I never saw the lymphatic involvement in that. So this is where the whole light bulb sort of went up and said, okay, hold on a second. You got this. You got the interstitial fluid. You got all the absorption and all the processes going on here. What is the role of lymphatic system? And what if there is a connection between all of these? And maybe the problem starts right here, and this is the source of it. So looking at the lymphatic system and venous structure, there are similarities. The lymphatic is analogous to venous anatomy in a sense that they all have a structure of vessel wall. They have two different systems, superficial and deep system. And most importantly, they have unidirectional flow. And we know the problem starts when that unidirectionality disappears. And unlike venous system, of course, superficial system has greater involvement compared to its deep system. Next slide, please. So I think the next thing that was trying to find out, okay, how these things are going to link to each other. So an average 70-kilogram man usually has 10 to 12 liters of interstitial fluid compartment, and about 8 liters of it is a lymph, which is contain all the protein and all the larger molecules that cannot be absorbed into the capillary system of venous and arterial system. And what makes it important is throughout the absorption and transportation, this volume gets half by 4 liter and it gets concentrated. And here is the connection. 4 liter of it get into the venous structure. So there is a connection between the venous system and our lymphatic system that probably as a physician or medical students, we're kind of not really aware of it. And I think the problems start here. These are all systems that are connected to each other. They're intertwined and we have to consider them together. Arterial disease, as Dr. Compton said, is being treated, evaluated, diagnosed, and exhaustion. And I think we've done a great job with it as a cardiovascular specialty. But the other two has been always a problem. And we're still, as Dr. Rockson's work shows, there's a lot of uncertainty as how you diagnose them, how we treat them, where we start, when we start. And that's what these meetings are going to be really helpful for people who are involved in taking care of these patients. Next slide, please. So the lymphatic classification, as Dr. Compton addressed, is based on etiology. Unfortunately, that doesn't really help us with the management because we haven't come up with a plan of action at that point and how we're going to start treating these patients. And we all know the primary and secondary causes of lymphedema. I'm not going to get into that, and it's self-explanatory. Just remember the primary one has no triggering factor, and secondary one usually has an identifying cause. Next slide, please. So in our world of clinician, when we see edema, when we see a swollen limb, we automatically think of 4 things. Number 1, lymphatic, venous, arterial, and non-vascular lymphatic processes, such as obesity, congestive heart failure, renal and hepatic involvement, as well as the local causes, such as hematoma, tumors, or trauma. And again, as soon as we get edema, things get dicey and muddy, and we have no idea which direction we're going to go. And this is what I think these studies have been really helpful. Next slide, please. And in understanding the concept of when the treatment should start. I'm not going to go over these slides again since Dr. Compton did an amazing job of explaining them, but I want to draw attention to 2 different points that also was brought by Dr. Compton. Number 1, stage 1 of lymphedema, being the irreversible stage of it, is very important to capture these patients. So we really always in our clinics, we measure the leg, we take pictures definitely, and we of course exhaust the option of the conservative measures in terms of pressure gradient, compression stockings, leg elevation above the eye level at rest, and exercise. Next slide, please. Looking at this, the classification for chronic venous insufficiency, the C classification, the C3, which usually points to edema, is showing the part of this treatment clinically that becomes almost identical and parallel to what we have in lymphedema, as Dr. Compton said. And usually we've been approved by insurance to see these patients when it's already too late, when there is an ulcer, a healing ulcer, and damage has been done. I think our treatment and our efforts should be started not only for therapeutic reasons, but also preventive measure. That's what we have made in my decade and a half of working with Tactile. We have made this make a conscious decision that all these patients, in addition to the conservative measures for chronic venous insufficiency, will be also getting started on the flexor pump as well. And it has been amazing that to see that the national registry, which I'm going to come to in a minute, kind of correlates with exactly what we have come up with in terms of patients' result and outcome. So next slide, please. Speaking of the national registry, this is from Tactile medical results. And as you can see, over the course of a 34 months, they take the patients who have been treated by the pump and look at the symptoms that were initially brought the patient to the clinics. And it goes from edema all the way down to the wound healing and even using the jewelries and clothing for fitting. And it's amazing to see this pattern on all these patients who have been treated for lymphedema. And if our thought process was correct that there is a correlation between lymphedema and chronic venous insufficiency and treatment of all these together, coming down to the source of edema, starting it early, would that have the same impact on these patients as shown in the national registry, which takes us to the next slide, which is mine. Next, please. This is our data from our patient population over the same course of the month. We have a high volume clinics working in Arizona and California, and this is a composite of what we had done over the course of the last 34 months. And you can see kind of a matches and overlaps with what the trend has shown nationally. So I think from a clinical perspective, as a cardiologist, we always tell the patients, take your Lasix, go work out, lose weight, watch your diet. The problem is they can't walk, they cannot lose weight because they have a limiting factor. That's a lower extremity. So I decided that if we fix the lower extremity problem they have with it, if we enhance their lifestyle, get them out there walking, not only the lymphedema and CVI will show improvement, but also their need for diuretics and a lot of other therapy for unrelated issues such as hypertension and diabetes. So as a clinician, this is what we do in our clinic. We're treating the same CVI patients with a C classification C3 and more with lymphatic pump. As a matter of fact, I've taken upon myself to put a lymphatic clinic in my clinics. I have patients here that we bring in to educate them, to show them what it can do. We do a demo on them, and the results are amazing after 18 minutes of treatment, what you can accomplish with these patients. And that has caused them to remain very compliant with the lymphedema treatment. I usually like to have them on it non-stop for about a month or two, but then we reassess and evaluate if they need to stay on it or not, and they make the decision themselves to if they want to continue with it 2 to 3 times a week, which I'm okay with that. So this is where we are, and I'm really happy Dr. Rockson has pointed this out and brought this up. I think it kind of shed light on what we've been doing for all these years, and thank you for paying attention and listening, and if there's a question, I'm more than willing to take. Thank you.
Thanks, Armin. Any questions from the panel or discussion?
There's a question here, since we have Dr. Foghi here, there's a question from the audience about what are the recommended ejection fractions for patients with CHF and lymphedema? And I'm wondering if they're saying, is there a limit to who you can offer pneumatic compression pumps for based on their congestive heart failure?
Well, I think it has to do with what kind of a congestive heart failure we're talking about. I mean, there are different etiologies for that. Am I correct? So if you have ischemic, non-ischemic congestive heart failure, if there's a vascular involvement, it's the same question you can ask if the patient have venous insufficiency. I wish it was a kind of a clear-cut answer for that, oh, if you have an EF less than 30%, let's just start to pump on them. It usually doesn't work that way. I think it's a multifactorial kind of approach to that. If diuretics work and the patient has no further edema, I think there's no need for a pump. If you do the venous treatment and the edema disappears and need for the diuretics disappear, there is no reason for pump. But I believe as long as there is edema and there is residual of this symptomology after other approaches that we have had, I recommend it regardless of the fraction.
Yeah, I think it's listed as one of the, contraindications to initiating pneumatic compression is significant CHF. And I'm not a cardiologist, but what I've done in my practice is if somebody's walking into my office on room air, even if they have the diagnosis of CHF, I think it's very unlikely that by them using the lymphatic pump that they're going to put themselves into worsening congestive heart failure. But if somebody comes in to my office in an electric wheelchair and is on home oxygen, I'm going to be a little more conservative about initiating a pump. But for me, the diagnosis alone of CHF wouldn't preclude me from prescribing a pump. Does that sound reasonable?
Yeah, and let's go back to diagnosis of CHF. It's a diagnosis that's been given in ERs right and left without knowing exactly what the cause of it is. I mean, a pure CHF, they don't have a good longevity diagnosis. So we have to be very careful when we see those diagnoses. In my practice of cardiology, I always try to find out if there has been given an etiology attached to the CHF, not simply because they have had edema. There are a lot of diagnoses that are considered to be CHF is simply edema with no cardiac etiology attached to it. So I agree with you 100%. People who have comorbidity, you have to be careful with them in regard to everything. I mean, people who are vasculopath, I always give it extra attention and extra thought that if they have an arterial system, I usually don't touch them until those arterial problems have been resolved. People with a significant DVT or pelvic congestion syndrome, those are the people that usually don't do anything until I have those issues addressed first. So you have to take and give, and you have to look at the whole etiology. You cannot just take one and say, okay, EF can give me indication if I should treat them or not. But I agree with you 100%. Patient with the advanced stage CHF, probably they won't get that much of a benefit of treatment anyways.
A lot of questions on medical conditions and pump use. So I kind of agree with what you guys both said for that, CHF. But I mean, if they have stable CHF, then there's really no reason not to. I would do educate those patients though, in case they do start getting symptoms of CHF, that they should follow up with their cardiologist and hold off on the pump use to manage their medical. Maybe they need more diuretics or whatever. How about in the dialysis population? How do you guys manage those patients that have lymphedema? Are you offering treatment to them, or how do you?
Yeah, I mean, I don't again, like if someone's on room air, um even though they might be a little bit volume overloaded, I I have no reluctance to initiate static compression and or lymphatic pump in those patients. Now, if they're on oxygen in a wheelchair, that's different.
Yeah.
I agree with that. Patients who are, for example, in a renal list for transplant and very kind of advanced dialysis, they have other comorbidities. Probably they're not going to benefit from me to do much in terms of lymphatic treatment with them. However, if there's a significant venous insufficiency problem with these patients, I probably will address that. And if there is a room for lymphatic, I may consider it. But again, any advanced stage of any kind of a medical condition, you have to be cautious because you may shift the situation to worse than better. So we have to be really adjust patient to patient.
All right. Well, I think we'll wrap it up. I want to thank you, the panel here, for some great presentations. Really enlightening us now with Dr. Rockson's paper on the gap in care in these patients and how it affects their lives. Obviously, thank Tactile for putting this together. And as mentioned, this is recorded and will be available on the education website for Tactile for access after the event. And thanks everyone for participating, and look out for future events. Have a good night and enjoy your cocktail.
Great, thank you.
Thanks, everyone.
Thank you.
Thank you. Good night.
Good
Good
night.
night.